Next, I call upon Dr. Manju Anup, a senior glaucoma surgeon from Giridhar Eye Hospital, for her talk on management of glaucoma progression. Over to you, ma'am.
A very good afternoon to all. I'll be talking on management of progression in glaucoma. Detecting the progression and modifying the treatment at right time is very important in the management of glaucoma. We have already seen various methods to assess the progression, and once you have documented a progression, the next step is confirm the progression. For that you need good quality test and reliable test. And before confirming the progression, you need to look at the relation of the progressing location to the original location. Because in glaucoma, usually the progression occurs adjacent to the original location. Then look for accompanying clinical evidence. In case of any doubt, repeat the test. Now, you have confirmed the progression. What next? Whether you have to treat the patient or you have to observe and continue with the current treatment. For that, we should understand that aim of glaucoma management is to slow down the progression to an extent that minimizes the likelihood of glaucoma related visual disability and quality of life during the lifetime of the patient. So if you feel that this amount of progression is not going to affect any of the above factors, then you don't have to treat that progression. You can continue with your current medication and re-evaluate, and whenever you feel a higher rate of progression, then you can think of treating that progression. So once you have decided to treat that progression, then you have to look at the relation of your office IOP to the target IOP. Suppose you have not achieved the target IOP when the patient is progressing. Then you have to look at the compliance. You have to ask the patient whether the patient is using the medications every day at right time, whether they are missing the drops in between, and you can even ask how many bottles they have purchased since the last visit to look for the compliance. Also, make sure that the technique of installation is proper. Always do a gonioscopy whenever you see a progression, because the angles might be getting closed and that may be the reason for a progression. The another scenario is you have achieved your target IOP, even then the progression is occurring. Then you have to again look for the compliance, rule out other secondary glaucomas which could cause transient intraocular pressure fluctuations like uveitis flare-up or steroid usage, and rule out other ocular pathologies that can mimic glaucoma progression like vein occlusion, arterial occlusion, retinal scar, ARMD, etc. Again, gonioscopy is very important, and then do a diurnal variation of tension, if possible 24 hours, to look for any pressure which is going up beyond your target IOP outside the office hours. Also look at some systemic factors. You have to ask for specific yoga postures, whether the patient is doing any Shirshasana, which can cause progression. Then use of wind instrument. Sleep apnea, many studies have found that sleep apnea has a very good, very strong association with glaucoma. And next is you have to look for any nocturnal hypotension, especially when the patient is a hypertensive and using the antihypertensive medication at night. So for which you may have to do a 24-hour BP monitoring and rule out a nocturnal hypotension. If the patient is on antihypertensives at night and you find out a hypotension, then you have to ask the physician whether they can change the medication to morning or at least to evening. Look for any evidence of reduced ocular perfusion, for which you may have to do a carotid Doppler, neuroimaging or cardiac evaluation. So once you have ruled out everything and you find that there is still a progression which you have to treat, then you have to augment the therapy. So before deciding what next, you have to consider following factors: that life expectancy of the patient, rate of progression, severity of the disease, and the number of AGMs which the patient currently on. Suppose the patient is an elderly patient, slow rate of progression, mild to moderate disease, and patient is only on 1 or 2 medications, then you have to think of a medical or laser procedure. Suppose the patient is on single drug, which is a beta blocker or carbonic anhydrase inhibitor or an alpha agonist, switch to prostaglandin agonist because it gives further IOP reduction with single drug. If the patient is already on a prostaglandin analog, you can add another drug, maybe a beta blocker, and you can give a fixed dose combination. You can try laser trabeculoplasty also. And if the patient is young and he is a fast progressor and it's an advanced disease and patient is already on maximum medical therapy, then you have to consider a filtering surgery. In case of angle closure, you can consider a YAC iridotomy or a cataract surgery. We'll just look at 1 or 2 cases. This is a 78-year-old male who had undergone YAC-PI in both eyes and on an AGM after that. Later he underwent cataract surgery and he had a pseudo-exfoliation in the right eye. So patient was on 3 anti-glaucoma medications and the left eye was primary angle closure disease which was stable, and the right eye he had PXF and the intraocular pressure was 18, and the patient is already on 3 medication with an advanced damage. So his fields were showing progression which was confirmed with imaging, which was also showing progression both in RNFL and the GCL. So considering the advanced damage and the patient is already on maximum medical therapy, the patient was advised a filtering surgery. This was another lady. She was 69-year-old female. She underwent YAC-PI in 2018 and following YAC-PI her angles were open with a few peripheral anterior synechiae and her intraocular pressure was 18 millimeters in both eyes without any anti-glaucoma medication. Fields and OCT were done in 2019 which were normal and the central corneal thickness was 520. This was her fundus picture in 2019. Then she lost for follow-up with us because of COVID time, and then she reviewed in April 2024. She was not on any anti-glaucoma medications and her intraocular pressure was 22 millimeters at that time. Gonioscopy was same. So this was the picture in 2019, and in 2024 both the discs were showing advanced damage with RNFL defects. And intraocular pressure was 22 millimeters. Her fields and OCT were showing significant damage in both eyes and she was started on prostaglandin analogs. Her intraocular pressure had dropped down to 14 millimeters of mercury in both eyes. Then after 6 months, she was reviewed in November 24 and her intraocular pressure on diurnal was maximum was 16 in the right eye and 18 millimeters of mercury in the left eye. However, her fields and OCT were showing minimal progression in the right eye, but there was a significant progression in the left eye. So we ruled out all other causes for her progression, including MRI, carotid Doppler and VEP, all were within normal limits. So considering her pressures in the high teens, we reset our target IOP and added brinzolamide eye drops. However, there was not much reduction in the intraocular pressure, so I changed the medication to brimonidine. So now she is on brimonidine with prostaglandin analog. She is yet to come for the follow-up. So before deciding to augmenting therapy in progressive glaucoma, you have to confirm the progression, assess the rate of progression, assess the severity of the disease and consider the life expectancy of the patient, because our aim is not to treat just the intraocular pressure, disc or field, but to treat the patient as a whole so as to provide maximum benefit with minimal side effects. Thank you.
Thank you, Dr. Manju, for the excellent talk based on clinical scenario. Any doubts or any questions? To conclude, basically, the management of glaucoma progression is to first confirm the reliability of the test and to confirm the structural function correlation, then to confirm whether the patient is having the progression and what is the rate of progression and manage accordingly. Any doubts or? Usually there's one doubt I have, like there's a discrepancy in the structural and functional progression. Like there is a structural OCT, there is a progression, but visual field is like remains static, or visual field there is a progression, but OCT is like static. Start. Normal and change the management. Okay, thank you. Thank